Thank you very much, Beverly. I have the privilege of being the Welsh director for Lifeblood, but I am not Welsh, I'm English, and therefore it is a privilege to be in England because I tell you what, the last week my colleagues and patients have been damn chopsy about the rugby, so it's very nice to be kind of amongst people who aren't just going, kick it to the corner, throw it to the front of the line out. So, how do we look at the cost of thrombosis? And often when we're talking to policy makers and we're trying to convince people about the importance, it always seems that money's the thing that kind of talks. And, when we say what is the cost, we will often have press releases where we'll talk about deaths. We will talk about the cost to treat deep vein thrombosis or the cost of post-thrombotic syndrome. But when you look at all these things and all the different ways that these things cost, I don't see a face there. I don't see a patient. I don't see a person. And actually, how do we understand the importance of this without actually talking to our patients? How do we as healthcare professionals know how to guide our patients unless we do what I call something very old school? We listen to them. And so that's what I've been trying to do with some of my research. My main areas of interest are cancer-associated thrombosis and also patient experience, because it's clear that, I remember, once a surgeon once saying, the operation was a complete success, but actually the patient's life was never the same after. Their life was devastated, although technically it was a great operation. I mean, that's no good, is it? So we actually published a study last year about the long-term psychological consequences of thrombosis. And it was done with a colleague of mine, Paul Bennett, who's a professor of psychology, because he's done a lot of work looking at people's experiences of heart attacks, people's experiences of genetic testing for cancer. And he says, these things are really distressing, and actually there's long-term distress cause. And I said, well, this sounds just like what my patients go through, what I see there. So let's do a formal study, because whenever I tell people about this, it's kind of, well, where's the evidence? So we basically did a study in which we interviewed patients who had had large burden pulmonary emboli. So I say large burden, we're talking about people who were hospitalised for a PE. And why did we choose that group? Because we thought if that group haven't experienced some distress from this experience, it would be less likely that people who've had a small asymptomatic DVT, for example, would be distressed. So we actually loaded the dice to actually look at what are the experiences of people who've had catastrophic events. And these are the main themes that came up. And actually just listening to Alison this morning, so many of the things that she said resonated because these are things that were said to us by our patients. And so these are the major themes. First of all, as a junior doctor, I remember when I used to give patients treatment for DVT, and I'd think, there you go, you're sorted, 6 months, there you go. No, it's a life-changing event. Not just for those people who have ongoing thrombotic complications, ongoing DVTs and PEs, but these people have a life-threatening event and then live with that for the rest of their lives. The actual diagnosis is a shock. They describe a feeling of loss of self, changes in their focus sometimes in their lives. And we'll go through these things now. So these are real patient quotes. So they considered the diagnosis a shock, that I just couldn't understand what had happened to me, why me, and it was awful not knowing what caused it, not being able to understand it. Living with uncertainty, that's something that we really struggle with. And we know when we look at people who have a diagnosis of post-traumatic stress disorder for any condition, it is often the uncertainty and not knowing what the future brings that is a major part of that. Some people talk about loss of self. They go from being fit, healthy, and now they've had a condition which has either limited what they can do physically, or they're now on a medicine which limits what they can do. A young patient of mine who can't play contact sports now, a rugby player. someone who is nervous about, kind of playing with their kids. And some of these things will be exaggerated and amplified if you don't have access to the right information or the right support. Now, the thing that really surprised us, well, didn't really surprise us, was actually there seemed to be a prevalence of symptoms that people described which very much sounded a lot like the symptoms associated with post-traumatic stress disorder. And at first I thought, well, that's a rather kind of exaggerated thing. Am I actually being a bit too vitriolic here? One patient actually described what she calls post-thrombotic anxiety disorder, almost like a new syndrome, about this ongoing anxiety that she feels from it. And in people who'd had large catastrophic events, it sounded like they had PTSD. So what are the symptoms, or what are the things that lead to PTSD? I mean, these are the things you're talking about. You've got anxiety. You've got hypervigilance. You're not allowed to have a cold anymore. Your breathlessness, that's a PE. Your leg swells a bit, or your leg's a bit sore, or your hip hurts. It's not going to be just a common thing, that we all get aches and pains. No, this is a clot until proven otherwise. If you've gone through it once, you're hypervigilant about the symptoms. Some people talk about avoidance behaviours, trying to avoid anything that may precipitate it, or avoiding situations which remind them of their illness. Going to A&E, for example. Some patients have a fear of going to the clinic. So we talk about hypervigilance, and also some patients would also talk about having flashbacks to it. It was such a traumatic time, and the thing that really made it worse for them is if they didn't get information to actually help them know what to do, what do? You go on that anarchic library called the internet. And it's amazing what stuff you can find there. And you can, as much as you can find very good, very responsible information, you can also find very scary information. And even when that scary information happens to be true, when you're there on your own on the internet, do you have anyone to run that by, for someone to put it in context, to say how much that applies to you? And so the other thing that became very apparent with this study was patients' need for support. And it was often the lack of these things which precipitated the level of distress they had. So information, and people said, no one actually said anything to make me understand. It was just a case of you've had these clots, they're gone to your lungs. None of the rest of what else could have happened before they got to lungs registered, or how serious it was when I got there. And so, there's a well-known fact in consultations, which is patients remember 30% of the consultation. And that's not the fault of the patient. It's not even, always the fault of the doctor. It's just a fact of life. You will remember 30% of my talk, okay? If you can remember one bit, just that. Okay, there, I've just woken you up again, you see. So, you don't think at the time when you're going through this traumatic event, you don't think of all the right questions because you're trying to get your head around it, aren't you? And so then you go and you think, I wish I'd asked that, or one of your loved ones says, what about that? What about, I don't know, I didn't ask that, I just heard it's on my lungs. And so people don't always get the information they want or need. They don't know what they need at first until you start finding out. I might have died, that my daughter might not have had her mum and no one else helping to make sure that I understood what was going on or what was wrong with me or how this would affect my life. I just remember feeling quite resentful of the medical staff. Now, I remember from one of my experiences when my father was poorly and he had a drip. And he was terrified. He had a drip. That must mean he was very ill indeed. Because, if you have a drip on telly, the next thing that happens is beep, 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 crash team comes in. Whilst all the docs in the audience will know that a drip is basically a great cure for a hangover. Okay? And so, we often don't appreciate what may be distressing to our patients. So someone goes, it's a clot, fine, we treat it. That may either be our ignorance of the area, which is for some people, Or it may actually be, we have not registered actually how frightening this is. Now, we have guidelines. When we break bad news, we have guidelines, we're given advice. You can go on communication skills courses, which will say how you sit the person down, give them time, feed them the information, offer them availability to ask questions, offer follow-up, etc. So, usually when someone is told, for example, they have cancer, that will be done by the book. This is breaking bad news. But for those of you out there who've had a clot, how many of you had that news broken to you in a timely, sympathetic time, recognising that you needed empathy, recognising you need information, etc.? And yet, you're being told that this is a potentially life-threatening event. People look for support from each other. They need information. They need to understand the thoughts, the feelings they're having are normal for what they're going through. Where do you get that from? So people may talk about perhaps would love to have some group thing or something. So I think, the Thrombosis UK buddy system, some of the chat rooms, I think actually the work that Thrombosis UK do in that, is brilliant. But isn't it a shame we've had to do that? Thrombosis UK only exists because there is an unmet need there. I don't think I'd have felt so on my own then. Just to have this level of conversation with somebody back then would have helped massively. To help me process it all, though, because it was very much off you go. So there's a running theme there, isn't it? Now, interestingly, this was another paper that was done after, and Thrombosis UK and many of our patient partners associated with Thrombosis UK took part in this questionnaire, as well as other patients. And what we identified here was that it is not just people who have massive catastrophic PEs who have ongoing anxiety. Anyone who's had a clot, may go on to develop anxiety, may find the process distressing. So what are we going to do about it? It's one thing to say, well, there we go, we've pointed out it's a big problem. What are we going to do about it? Clearly, education is important for healthcare professionals to understand what our patients are going through, understand the time and the information they need. The other thing we're trying to do is introduce an intervention at the beginning which can help reduce the anxiety and distress that patients experience at the time of diagnosis. And so we have a PhD student at the moment, Rachel Hunter. She's absolutely outstanding. She's working with myself, Paul Bennett, Professor of Psychology, in developing an intervention which is pretty much a self-help information about what it means to have a clot. Basically all the questions people were asking at the time, all the things that came through about this is what I wished I'd known, this is where I wished I could have got information from. We're trying to introduce that intervention, and we're going to be seeing, does that help minimise or reduce distress? Now, finally, I just want to talk about a different patient group. It's a patient group I see 340 new patients a year, cancer patients who develop blood clots. Now, interestingly, 50%, what time am I on till? Sorry? Okay, 5 more minutes, then we can chat. Cancer-associated thrombosis is a different beast because the cancer itself makes the blood more sticky. Treatments will make the blood more sticky, especially chemotherapy. And we know that 52% of people who develop blood clots in their cancer journey get them in the first 3 months, because that's where you're getting your cancer treatments. To put it in context, someone who has early stage breast cancer, without chemotherapy, the rate of blood clots is 0.2%. But you give them adjuvant, so curative chemotherapy, the rate goes up to 2%. You look at pancreatic cancer with chemotherapy, 25% of people may get blood clots during chemotherapy. So it varies between cancers. Now we know that the injectables, the low molecular weight heparins, actually work better in the treatment for these. But what about being a patient during this? What is it like to be a patient? So we did a study where we interviewed patients with cancer-associated thrombosis. And that's a busy slide. Don't worry, I'm going to break it down. But what they do is they describe life before cancer-associated thrombosis, the time when they were diagnosed and started treatment, and then getting on and living with cancer-associated thrombosis. Now, the majority of patients would go from a position where they had no symptoms at all, then develop the symptoms and were diagnosed. There is a proportion who they find on a CT scan, which is staging the cancer, they have clots there. Now, those ones have quite a traumatic time because they talk about just getting a phone call. Hi, it's the radiologist here, or hi, it's one of your cancer doctors. We found a clot on your lung. Can you please come in? It's potentially fatal. Would you mind popping in? That's what they describe. Can you imagine someone being told over the phone, your loved one has died, or being told, you've got cancer? You just wouldn't think of doing that. And yet people are being told they've got a potentially life-threatening condition over the phone. The other thing that was interesting here is that patients would describe very clearly what they were warned about during chemotherapy. They were warned your immune system's going to be affected, so you may get an infection. And if you do, here's a phone number, here's a patient pathway. We've got a chemo pager person who will pick up the phone and give you advice. Come straight in, we'll do blood cultures, we'll give you antibiotics. Now, an interesting fact, the largest cause of death during chemotherapy is not sepsis, it's not infection, it's clots. We have wonderful pathways in all our cancer centres, in our hospitals, what to do if you have a suspected infection. But patients were telling us that they are not being told what I call the red flag symptoms, which suggest a DVT or a PE. So what do people do? Nothing, because they've not been told they need to. And they would say, well, you know, no one told me the signs and symptoms of clots. So these people would just wait until their next appointment, and then all hell breaks loose. Everyone goes, oh, they may have a clot, quick, get them scanned, give them the injections. Now, as you guys know, the longer you sit on a diagnosis of a clot, the greater the chance there is of that becoming, more serious, the greater the chance there is of that becoming established post-thrombotic syndrome. So this is not just about preventing fatal clots, which is obviously essential, but it's also about preventing long-term complications. I have patients now who have been cured of their breast cancer. Fantastic. But their life is a misery because not only do they have lymphedema in the arm where they've had the breast removed, so they've got their lymphedema stocking, they also have their grade 2 compression stocking for the extensive thrombus which has now caused post-thrombotic syndrome. So for the rest of their lives, even though they've been cured of cancer, they have the after effects of it. So patients actually find this a distressing experience, as we found before. The diagnosis, just being told very quickly. And this is happening when you're already just started your cancer journey. So that some people talk about it being the icing, the cherry on the icing. So I'm going to move on now. These slides will all be available for people online. Yeah, we're putting them online, aren't we? Yeah, you can have them to go through then. And also I've put the reference there. It's open access, so you go on the internet, you can find it. And then people, as I said before, go on the anarchic library of the internet, find out all sorts of distressing things. They need information. So I'm just going to kind of move on now. What I love about patients is they are resilient, they are adaptable, and actually people then get on with their lives. They do their best to get normality if they can, if we can support them to do it, if their friends and family support them to. Because the cancer is not what defines our patients, neither is the clot. People have been on this planet many years before they've had these things. Clots do not define patients with thrombosis. Okay? Well, that's my opinion. I love this patient. They're doing their injections because it gives them freedom. Everyone said to me, oh no, patients don't want to do injections. Oh, it's horrible. This guy actually says, no, I get more freedom to do what I want. I don't want to be waiting at home from the warfarin nurse to tell me what dose to take today and then I need another blood test. I just get on with it. My life is my own. And this one, she's my favourite. It's me injection time. I've got to have my jab, I go to my bedroom, shut the door, got to pull this up, pull that down. It's like this kind of heparin Macarena sort of thing. So, what's the future hold? Well, we know that thrombosis confers a significant psychological impact. Basics. You know, we're doing great. We've got new drugs coming out. We've got new ways of monitoring X, Y, and Z. But the basics need to be done no matter how good our anticoagulants are. If we're not getting it right at the beginning, if we're not having decent pathways for looking after patients, diagnosing them, if we're not breaking this information to our patients appropriately, giving them access to support, great, the clot's gone, but what have you got left? You've got someone who's been traumatised by this experience. It may be that there are certain people who are more likely to be distressed, and we may be able to target them. And what I would say is that the personal and emotional cost of the VT experience must be recognised by clinicians, by policymakers, and also I would say the academic journals as well. Because qualitative research, you know, has a fairly small priority in some journals. And so I'd like to start seeing some of our thrombosis journals kind of embracing this a little more. So thank you very much for your time. I'm very happy to answer questions.
So Simon made that last comment because he's had a little bit of a run-in, haven't you, with general thrombosis and hemostasis.
Yeah.
Say anything about it?
Yeah, I will. I gave a talk for the scientific subcommittee for cancer and thrombosis in Toronto at the ISTH, and it was called Qualitative Research, Cancer-Associated Thrombosis, Who Cares? And the first thing I did was I just put up all my rejection letters, and I then talked about how qualitative research was useful, because if I were to kick the editor of the Journal of Thrombosis and Hemostasis in the balls, what would be the best way to evaluate it? Because if we used a pain score, it would be 10 out of 10, and so it doesn't discriminate. And if we used a validated risk assessment, you know, a validated quality of life tool, it would only pick up functional ability over the last month. So it's much better to actually talk to people about what it means. And all this thing about p-values, well, you know, how many men in the audience do I need to kick in the balls before we are convinced it actually hurts? I'm not worried about stats then. I just don't want to be the person in the front two rows. So I was kind of slightly controversial, but I think the point was well made.
David.
Simon, thank you very much. And I think this kind of work is absolutely imperative in all of medicine, not just thrombosis. Is there a bit of nihilism here amongst the cancer community?
Yeah.
So like, actually having a PE might be a nice way to die?
Yep, there is. And there's a couple of things to answer there. First of all, I was actually speaking to a journalist yesterday, and they actually said, well, why are you kind of getting so excited about these clots in cancer patients? Aren't they all going to die? And a large clot is a nice way to die. I've worked in a hospice for many years. We have handovers, and the following day you may hear that someone died suddenly, and we think it may have been a PE. I've not known a single one of those patients have a report, oh, it must have been a PE. How do you know? Because they looked so serene and happy, because it's such a nice way to go. There is a study in 1977 by someone called Havig, who actually looked at post-mortem data and the notes of people who died of a PE. And what it showed that 60% of those people, it took 2 hours to die, distressing symptoms. Very few of them did they identify the PE as the cause of their symptoms. Now, I think there is a bit of nihilism, but also if I am to use stereotypes, and I'll start with me. I'm a palliative care physician, so all I do is give morphine and talk to nuns. So if I've done that, if I've used that unfair stereotype, I can now basically say that oncologists just want to give chemo. And and when they actually talk about, oh, this person's on low molecular weight heparin, we've stopped the chemo, you can put them on warfarin now. And it's like, I didn't give them low molecular weight heparin to help you give more chemo. It's because it's the drug with the best evidence. So I think people are very focused on things, and you only deal, they see it as something which gets in the way of the treatment rather than a major problem. And so we need to increase their awareness as well.
I think you've stunned everybody with your honesty and your clear words. So.
I'll just say something.
Yeah.
You're quite right about PEs.
Yeah.
I've got two. My daughter died sadly of PE very suddenly, but then my father was diagnosed with PE, and that was a cancer. PE, and that he was treated for months before he died. And when he did die, it was 7 hours of agonising time for the family because of what he was going through. So it's not.
No, not at all.
And I think GPs, and not just GPs, but the medical profession should recognise that it's not getting diagnosed, it doesn't happen that quick.
What I would also say is that this research is something which has directly influenced some of the work that's now going on. And, I know that Thrombosis UK have recognised how important it is that we look at the cancer patients as well. And that's why we have this report which has been released today, which is a real call to arms to ask cancer centres, people who are involved in looking after cancer patients, to actually think about clots so much more and advise patients about clots. So I'm hoping, thanks to our patients who have participated in this research, we're trying to use that data now to directly influence health policy so that we kind of improve things for everyone.
Thank you. One very last question, because I know you tried before.
Sorry.
This is not licensed use, but often our clinicians are asking whether there are any other centres using NOACs to treat cancer-related thrombosis. Self-administering low molecular weight heparin for a minimum of 6 months can be quite...
Yeah.
Do you want to talk about the trials?
Yeah. I think you're absolutely right. For some patients, self-administering or having it administered to you an injection for 6 months is quite a burden. From my experience, there is a proportion of patients who are unable to tolerate that. I find the majority will, and we've actually done some other patient interview work in which patients have said, what I want is, I wouldn't ask for the second best chemotherapy or the second best surgery, so I'm not going to ask for the second best treatment for my clots. Now, at the moment, we know from the data that Matthew showed, the NOACs are non-inferior to warfarin for the treatment of thrombosis. Those studies did have a small proportion of patients with cancer in them, but all we know, therefore, at the moment is it's as good as, maybe a little bit better than, from a bleeding perspective, warfarin. But we know that warfarin is not as effective as low molecular weight heparin. That's number one. There has been a subgroup analysis of the Einstein study. They had over 700 patients in that study, in which they compared the rivaroxaban patients with warfarin, and rivaroxaban was better. Clot number was 5% compared to warfarin, which was 5. But those numbers are incredibly low, and when you look at it, the patient population were early stage cancers, very few of them were having chemotherapy, very few of them had metastatic disease. So the population wasn't representative of the patients out there that we're giving it to. And so I don't think we've got enough data yet. And I think, our patients deserve the best treatment, and that treatment, when it's the best, we need to know it's the best. And so I do know people are using it, but we're also seeing that patients, when we've interviewed them, say they prefer the best option first and one that doesn't interfere with their cancer treatment.
And we've got ongoing trials. So there's Select-D looking at rivaroxaban, there's an apixaban trial, I think edoxaban
that's
trial.
Right.
So we know the answer. And one of the concerns is the NOACs might interfere with the chemotherapy. So we need all those answers before we go down that road. So exciting times.
It is, absolutely.
Thank you so much, Simon.